Hello everyone. Today we are going to see the most important topic which everybody should learn while working as an intern or as a medicine resident in ICUs. The topic is hyponatremia and how to approach it practically. So a 60-year-old male presented with complaints of altered sensorium in the form of decreased responsiveness and incoherent speech. He was diabetic for the past 10 days. He is known case of COPD for the past 20 years and the serum sodium was 107 milliequivalents per liter. So he was a diabetic and COPD, and he now present with complaints of altered sensorium and decreased responsiveness. Hence, clearly it is a case of acute symptomatic hyponatremia. Okay, what should we do? Wait. Don't start 3% saline before doing this. We have to do serum and urine osmolarity. You have to take urine sodium spot, and you have to do collect samples for TSH and serum cortisol at the same time. Before doing this, never ever give 3% saline in a haste. Only after this, you have to give 3% saline because giving 3% saline can alter these values. These values are very important in diagnosing the cause of hyponatremia. So, symptoms guide the treatment. As patient was having altered sensorium and the sodium levels were 107 milliequivalents per liter deciliter. Hence, clearly it is a case of acute symptomatic hyponatremia. If patient is symptomatic, we have to always treat the hyponatremia. Hence, patient was started on 3% saline. Okay, how to give? We can start with 100 ml of 3% saline as a bolus, which shall be given over 10 minutes. With this one bolus, symptoms usually resolve, as I saw in my experience. If symptoms persist even after one bolus, we can give two more bolus of 3% saline. That is 100 ml of 3% saline. We can give two more boluses over 10 minutes with a minimum of 20 minutes between each doses. So 300 ml of 3% saline can be given over 1 hour. The target should be around 4 to 6 milliequivalent per liter, which means the target in rising the sodium level should be around only 4 to 6 milliequivalent per liter, which means from 107 the sodium should be increased up to maximum of 113. That should be our target, and sodium should be repeated every Q4th hourly, and never increase sodium more than 8, as there is increased risk of a syndrome called as osmotic demyelination syndrome, also called as locked-in syndrome. So this is a clear-cut scenario where they are showing locked-in syndrome. What happens is the patient was having acute symptomatic hyponatremia and he was lethargic and he was disoriented. And 3% saline was started. Within 1 day, 3% saline was started and the sodium has been increased from 106 to 118. So nearly around 12. As I told, we have to increase only up to less than or equal to 8. The target is 4 to 6. Up to a maximum of 8 we can correct. But here they have corrected up to a maximum of 12 milliequivalents. So after 2 or 3 days, there was nothing. But at the third day, patient developed pyramidal signs and he also developed coma, and this has progressed into what is called as locked-in syndrome, where there will be demyelination in the central pons. This leads to what is called as central pontine myelinolysis. As we all know, pons is a structure where these corticopyramidal fibers are densely structured. Any lesion there can lead to spasticity in both upper limb and lower limb along with weakness. And this is also called as locked-in syndrome. Means patient will be quadriplegic and only he will be having extraocular eye movements. So what they have done after that is they have again induced hyponatremia. So the patient's sodium values decreased over 120 over the next 2 days, and once they have again decreased, there is some alleviation of spasticity and full neurological recovery. Although I have never seen this. So symptoms resolved, and our patient's sodium increased from 107 to 111. So up to 4 milliequivalents we have increased, and there was no risk for ODS. So now what? Since patient sodium has increased, patient symptoms resolved, he was started talking. What to do now? Now what? So now what we have to do is we have to evaluate the cause for hyponatremia. Why hyponatremia happened? So this why will be helped by the investigations which we had sent already. Serum osmolarity, urine spot sodium, TSH, and serum cortisol. Remember, the serum cortisol should be sent at 8 a.m. and TSH is usually, as you know, sent in fasting. Yes. So now we have to find the cause for hyponatremia. Before finding the cause of hyponatremia, we have to separate these patients into three categories. How we can separate? Number one, volume overload state. Number two, dehydrated state. It is hypovolemic state. So this is hypervolemic hyponatremia. This is hypovolemic hyponatremia. And third is euvolemic hyponatremia. So hypervolemic hyponatremia, we have to check for signs of volume overload. That is looking for pedal edema, presacral edema, anasarca-like features. If patient is having pedal edema, anasarca-like features, then the possibilities are three failures: renal failure, liver failure, cardiac failure, and to a certain extent, nephrotic syndrome. So if patients are having these three failures and there are considerable evidence suggesting that, then we can go in treating that. So we can start injection Lasix and continue 3% saline. Remember, 3% saline should be continued up to a maximum value of 120 milliequivalent per liter of serum sodium. After that only you have to stop, and 3% saline should be continued at safely at 30 cc per hour. And fluid restriction along with this suffice. Remember, Lasix causes increased free water excretion. Compared to sodium loss, the free water loss will be more. Hence, Lasix will lead to relative increase in sodium in the blood levels. That's why we are using Lasix as a diuretic, because it decreases the volume overload state and it also increases the relative value of sodium in the serum. But thiazides increase both sodium and water excretion, thereby leading to absolute decrease in sodium levels. Hence, Lasix is the preferred diuretic in patients having renal failure, liver failure, and cardiac failure for this particular reason. Now, coming to the second cause, we can, as we had already seen, hypervolemic. Once hypervolemic hyponatremia has been ruled out, now we have to look for hypovolemic hyponatremia. Under hypovolemic hyponatremia, as you can commonly know, the common causes of hypovolemia are diarrhea, vomiting, burns, and to a certain extent pancreatitis, because it accumulates a large amount of water. Patients will be in severe dehydration in pancreatitis patients. Hence, diarrhea, vomiting, burns, and pancreatitis can also cause hyponatremia. But remember, these conditions will never, I have never seen these conditions causing acute symptomatic hyponatremia in a medicine setting. But you have to keep it in mind, since the sodium is lost here via loose stools, that is vomiting and burns and pancreatitis, there is no net excretion of sodium in the urine. Hence, in these conditions, urine sodium will be less than 40, as they have already mentioned here. But the most important thing which we have to look for is the urine loss of sodium in hypovolemic hyponatremia, which happens only in two conditions: thiazide diuretic use and cerebral salt wasting syndrome. Just remember these two causes, thiazide diuretics and cerebral salt wasting syndrome. We can come to them later. So, first of all, we have to see patients whether they are having hypervolemia, and we have to rule three failures: renal failure, cardiac failure, and liver failure. Then look for obvious signs of dehydration, and most often it will be renal loss of sodium. If patient is dehydrated, commonly thiazide diuretic use and cerebral salt wasting syndrome. Along with this, I have to add one more important cause, that is non-oliguric CKD. That is not CKD exactly, it is CTID. Here, since the tubulointerstitium is damaged, patients won't be able to concentrate urine and they will be having polyuria Along with that, serum creatinine will be around 8, 7 or 8, and patient's kidneys will be contracted. This is also in form of CKD, but it affects the tubulointerstitium. So this also you should keep in mind. And patients with CKD can also develop hyponatremia without being hypervolemic if they are non-oliguric CKDs, particularly CTID spectrum. Okay, now we have ruled out hypervolemia and hypovolemia. The next thing is euvolemia. Only three causes: SIADH, Addison's disease, and hypothyroidism. Of this, Addison's disease will usually give clues like abdominal pain. Patients will be having extreme darkness of skin. The skin hyperpigmentation will be present, and hypoglycemia will also be present in these patients. And hypothyroidism, patients will be having symptomatic hypothyroidism. They will be having hoarseness of voice, excessive weight gain, etc., etc. But the most common cause is SIADH. So, in all, if patient you have seen the patient and patient is neither hypervolemic, there is patient is not dehydrated and patient is not in volume overload state, then the only one left is euvolemia and patient should be euvolemic, and the most common cause is SIADH. But remember, SIADH is the diagnosis of exclusion. Hence, you have to do TSH level and 8 a.m. serum cortisol level before proving SIADH. So once you do that and the report comes normal and if patient is euvolemic, then the most likely diagnosis will be SIADH. We will discuss SIADH in detail in few slides. Remember, SIADH is a diagnosis of exclusion. So now you can guess why we did serum osmolarity, urine osmolarity, urine sodium along with TSH and 8 a.m. cortisol in the first place before even studying 3% saline. I hope you understand that concept. So the residency experience. What are all the common causes of hyponatremia? SAADH. Yes. The three failures: renal failure, cardiac failure, and liver failure. Cerebral salt wasting syndrome. Along with that, the non-oliguric CTID leading to hypovolemic hyponatremia. So when to suspect SIADH? Coming to SIADH, it is a syndrome of an inappropriate antidiuretic hormone secretion. Suppose the body is having some stress, the stress will lead to increase in ADH secretion. This can lead to increased water retention. As we all know, hyponatremia is a disorder of excess water in the body rather than excess sodium. The water will increase in excess related to the sodium, leading to low sodium concentration. So increased water. So water retention will lead to increased water retention, and patient will be euvolemic, but in hypotonic hyponatremia state. So what are all the stresses? The common stresses include lung infections like COPD, bronchiectasis. As I had shown here previously in my case, the patient was having COPD for the past 20 years. So there's a very good chance that this patient might be having SIADH. Any CNS pathology, drugs, particularly NSAIDs, carbamazepines, and SSRIs, even nausea can trigger SIADH, pain can trigger SIADH, any forms of stress, and CA lung, gut, and that is genitourinary tract, and GIT, that is gastrointestinal tract. Remember the causes, very, very important, particularly chronic lung infection. So the pathophysiology, as I told, any stress can lead to increase in ADH. So this increase in ADH leads to kidney conserving more water related to the sodium. Hence, there will be increase in urine osmolarity. This is not serum, this is urine osmolarity. Since water is conserved more, the urine is relatively concentrated, leading to increased urine sodium and increased urine osmolarity. Since water is conserved more, there will be decreased serum osmolarity, and patients will be euvolemic, and there should be normal thyroid, cortisol, that is thyroid, adrenal, renal functions along with normal 2D echo, and there should be no use of diuretics. This is the criteria for SIADH. Remember, there will be increased urine osmolarity, increased urine sodium, and decreased serum osmolarity. This forms the criteria for SIADH. Remember that. So, as I told, decreased serum osmolarity, increased urine osmolarity, increased urine sodium, euvolemia, normal other organ functions, and no recent use of diuretics. So, now coming to the case, a 65-year-old male with altered sensorium and neck stiffness presents to you, and LP was done, it was suggestive of TB meningitis, that is lymphocytic pleocytosis with increased protein in the CSF was present with mild decrease in glucose, which is classical of TB meningitis. CSF gene expert was done and was positive, hence ATT was started, and the sodium was also low, and it was corrected with 3% saline. What is the cause? Is it SAADH? As I already told, any CNS cause, any CNS pathology can trigger SAADH. Could it be SAADH? But remember here, there is no mention of the volume status of the patient. As I already told, volume status of the patient is very, very critical. Here also they have done based on investigation, serum osmolarity was low, urine osmolarity was high, and serum uric acid was low. This is also criteria favoring SAADH. But is it really SAADH? No. They have not mentioned the volemic status of the patient. That is whether the patient is having euvolemia, hypervolemia, or hypovolemia. They have not yet mentioned. So the patient was clinically dehydrated and he was having urine output of 5 to 6 liters per day. That is more than 4.5 liters per day, which is suggestive of poly, sorry, polyuria. So this there comes a condition called as CSW, which is cerebral salt wasting syndrome. Remember, I told when you look for signs of dehydration, just forget about the non-renal causes. The renal causes should be two, that is three. One is use of thiazide diuretics, and two is cerebral salt wasting syndrome, and three is CTID. The cerebral salt wasting syndrome should always be looked for in patients who are having polyuria along with hyponatremia. This patient was indeed having that, and this condition exactly mimics SIDH. Patient will be having high urine osmolarity, patient will be having low plasma osmolarity, low serum sodium, high urine sodium, and but the only difference is patient will be clinically dehydrated, but here patient will be euvolemic, and here there will be polyuria, but here there will be normal urine output. The management of SIDH is simple: fluid restriction and salt addition. But here in CSW, we have to give fluids and mineralocorticoid, for example, fludrocortisone. So the pathophysiology of cerebral salt wasting syndrome revolves around two pathologies. One, whenever a patient is having CNS pathology, there will be decrease in CNS sympathetic activity, which leads to decrease in renin and leads to decrease in sodium and water absorption, leading to net sodium and water excretion, thereby leading to hyponatremia. Another thing is there will be release of brain natriuretic peptide in cases of CNS stress. This can lead to natriuresis along with diuresis, leading to low sodium and low water. And these patients will also be having low uric acid, same as SARS. The only thing is patient will be having dehydration and polyuria. Treatment is isotonic saline along with fludrocortisone in order to salvage more sodium and water into the body. So, and another important condition called as beer potomania. These patients again will be euvolemic, but in SAIDH, as I told, since the water is being conserved, the urine will be relatively concentrated, leading to increased urine osmolarity. But here, the urine osmolarity will be less. That will be the only differentiating feature. Here, this condition is also called as self-induced water intoxication. That is, if you keep on drinking 15 liters of water per day, this leads to more water excretion along with sodium. So this also can lead to what is called as euvolemic hyponatremia. So take home points: all patients with symptomatic hyponatremia should be treated with 3% saline. Once you are treated with 3% saline, patients have become better. Try to find the cause. The causes can be divided into three: hypervolemic, hypovolemic, and euvolemic. Hypervolemic, three failures: hypovolemic, thiazide diuretic, and CSW, that is cerebral salt wasting syndrome, and CTID. euvolemic, SIADH, Addison's, and thyroid. So, in a nutshell, these are the important causes for hyponatremia. Look for causes of SAIDs, that is chronic lung diseases, any CNS trauma, drugs like NSAIDs and carbamazepine and SSRIs, any pain, any stress, nausea, and all of these are common causes of triggering SAIDH as well as CA lung, gastrointestinal tract, and genitourinary tract tumors. So SAIDH, the big three, and CSW along with CTID forms the most common cause for hyponatremia. If you had like this class and if you want to see more classes like this, subscribe to my YouTube channel, and further more discussions on ECGs will be available in the upcoming days. Thank you.